All right, prior to proceeding to this video, I'd like to ask for your permission to record and upload this video as unlisted onto YouTube for my professor to grade and view. Do I have your permission?
Yes.
Perfect. So my name is Renika. I'm the student nurse practitioner, and we're going to be doing your musculoskeletal exam today. I've gone ahead and washed my hands. So we're going to start off with the hands. I'm going to go ahead and inspect it. You know, you can see your hands. So as I'm inspecting, I'm looking for any swelling, deformity, redness, any muscular atrophy, masses, nodules, or joint symmetry. And then we're going to move on to palpation. When I'm palpating, I'm going to palpate the hands. We're going to start from distal to proximal, and we're also going to palpate the interphalangeal joints as well as the metacarpophalangeals. So as I'm palpating, I'm looking for any localized points of tenderness. So any tenderness, Gina?
No.
And I'm also feeling for any fluid collection that may have occurred. Do the thumb. All right, I'll do this one. Any tenderness?
No.
All right. Once we palpate the fingers, we're going to do range of motion. So for this portion, the patient will be doing it actively. So Gina, if you could go ahead and bend your fingers and thumb and form a fist, and this is testing the flexor muscles. And then we're going to do extension. So go ahead and straighten out your fingers for me. Perfect. After we test for extension, we're going to do adduction and abduction. So Gina, if you could have your hands out and if you could spread your fingers as much as possible, this is abduction. And then go ahead and bring it back together, and this is adduction. We're also going to assess the thumb. So if you can go ahead and put your hand out for me, Gina. So we're going to test for flexion. Go ahead and bring your thumb in, and then extension, we're going to bring it out. So that completes the hands. We're going to go on to the wrist. So first, again, I'm going to start off with inspection, looking for any redness, any swelling, any deformities, nodules. I'm looking for joint symmetry. And then we're going to move on to palpation. As I'm palpating, I'm going to be palpating the metacarpals and the carpal bones of the wrist as well. So I'm going to go ahead, any tenderness, again, looking for tenderness. And I'm also going to be attempting to move the carpal bones. When we're doing this, there should be little to no movement. Any tenderness, Gina? All right. Once we palpate, we're going to go to the range of motion. So for this one, you're going to go ahead and put your hands up, palms down. Palms down. We're going to start off with flexion, so go ahead and point your fingers to the floor. Awesome, and then extension, point your fingers up to the ceiling. Awesome, and then relax. And then next we're going to do adduction and abduction. So for this, Gina, for abduction, go ahead and move your fingers out. Awesome, and then for adduction, we're going to move our fingers medially. Perfect. So she has great range of motion. For the specialty test for the wrist, we're going to do the Tinel sign. For this one, we're going to hyperextend the wrist, and we're going to tap over the course of the median nerve in the carpal tunnel. So let me know if you feel any pain. So positive sign, the pain would radiate down their palm into their index, middle, and the lateral side of their ring finger. And any pain radiating to the other side? Any pain radiating? So if she did, that would indicate carpal tunnel syndrome, which in this case it is not. The next, we're going to do the Phalen's test. So for this one, Gina, I'm going to ask you to press the back of your hands together and make a 90-degree angle. So pushing them together. So this kind of forms a right angle, and this maneuver compresses the median nerve. We would do this for 60 seconds and ask the patient if they have any numbness and tingling. So Gina, any numbness or tingling? No. And if she did have it, that would be a positive sign. We would do it for the whole 60 seconds for the purpose of this video. We're just going to shorten it. Next, we're going to move on to the elbow. So I'm going to inspect again. We're looking for any redness, swelling, deformities, any nodules. We're looking for joint symmetry as well. Next, we're going to palpate. So when we palpate, I'm going to palpate the extensor surface of the ulna, the olecranon process, which is the tip of the elbow, the lateral and medial epicondyle. So I'm going to go ahead and also assessing for any tenderness. Gina?
No.
All right. And if the patient were to verbalize tenderness on the lateral side of the epicondyle, then that would indicate that the patient has tennis elbow, and that just occurs from the repetitive extension of the wrist and the pronation and the supination of the forearm. If they were to complain of medial tenderness, then it would indicate something called golfer's elbow, which can happen by repetitive wrist flexion, which is done by things like throwing. So once we've palpated and there's no tenderness, we're going to assess the range of motion for the elbow. So Gina, if you could just have your hands up for me and then go ahead. We're gonna test reflection first. So go ahead and bring your elbows in. Awesome. And then we're gonna test for extension. So go ahead and straighten your elbow. Awesome. And then we're going to test for supination. So Gina, if you can maintain that posture, and then go ahead and just open your hands like you're holding some soup. And then we're gonna assess for pronation. So I'm gonna have Gina turn her hand around, palms around. Perfect. Now we're going to move on to the shoulders. So like once again, we're starting off with inspection. So as I'm inspecting, I'm looking to make sure, I'm looking at the shoulders bilaterally, making sure that there's evenness. Again, no swelling, deformity, redness, atrophy, nodules, things like that. And for this, we're going to actually assess both from anterior and posterior. So once I've seen it from this side, I'm gonna go ahead and move back and look from this side as well. And look at the same things, looking for symmetry, redness, nodules, etc. Once we do that, we're going to move on to palpation. So I'm going to start off by palpating the acromioclavicular point, which is kind of the end of the clavicle. And then I'm going to move slightly down into the coracoid process, which is kind of into this groove. And then we're going to palpate the tubercle of the humerus, which is kind of here where the bones meet. And then we're also going to palpate the bicipital groove, which is kind of the groove in the shoulder, and the subdeltoid bursa. This is kind of, if she moves her arm back, go ahead and move your arm back, it's the tip of the shoulder, looking for any tenderness and fluid. So any tenderness, Gina. So I'm going to do the same thing on the other side, going into that groove. Any tenderness on this side. Perfect. Next, we're going to move on to the range of motion for the shoulders. So to assess for the flexion, I'm going to have Gina, if you can go ahead and raise your hand up to 180 degrees up. Awesome. And then we're going to do extension. So I'm going to have her move her hand all the way behind her. And she's going to extend the shoulder out backwards for about 60 degrees without moving her scapula. Awesome. Go ahead and relax. So next we're going to assess for abduction and adduction of the shoulder. So for abduction, Gina, I'm going to have you place your hands, your arms at the side, and then we're going to raise up to 90 degrees, and then go ahead and raise all the way up to 180 degrees, and that's testing for abduction. Now we're going to go for adduction, so go ahead and bring your arms down and across the midline to 90 degrees. Perfect. Next we're going to assess for the internal rotation and the external rotation of the shoulder. So Gina, I'm going to have you kind of turn your back towards the camera for me. And then, so for internal, we're going to ask her to place her hand behind her back. So Gina, go ahead and place her behind your back and try to reach for that scapula on the opposite side at about 90 degrees. And go ahead and do that bilaterally for me. Awesome. And then we're going to do the external rotation, which is kind of like scratching your back. So go ahead and raise your hand over your head and try to touch the opposite scapula. Awesome, and then the other side, and this one as well, we want to do it at a 90-degree angle. Perfect, turn back around. So lastly, for the shoulder, I'm going to have the patient perform a specialty test. It's called the painful arc test. This test involves the subacromial bursa, the rotator cuff, and it's used to detect presence of any impingement of that subacromial and to rule out any disorders of the rotator cuff. So Gina, I'm going to have you put your arms to the side. And then we're going to have the patient raise from 0 degrees to 180 degrees. And I'm going to have her verbalize if she feels any pain anywhere. So Gina, go ahead and start here and raise all the way up to 180. Any pain anywhere? No. Perfect. So if she were to have shoulder pain anywhere in that 60 to 120 degree area, this is a positive test and would indicate that she does have a subacromial impingement or a rotator cuff issue. And then moving on, we're going to go to the head and the neck. So again, we're starting off with inspection. I'm going to look at the head and neck. I'm looking for any deformities, abnormal posture, symmetry from side to side. Also looking from the back as well, looking at the same things. And then I'm also checking to see her trachea alignment to make sure it's midline, which it is, and also checking to make sure her muscles are aligned. Then we're going to move on to palpation. We're going to start off by locating and palpating the TMJ. So I'm going to place the tip of my index fingers right in front of the tragus of each ear. And when I do that, I'm palpating, I'm going to ask the patient to open her mouth. When she does this, my fingertips should kind of fall into that little groove in the mouth when it opens. And any tenderness here, Gina? Perfect. If she were to feel tenderness as I'm palpating that area, that would indicate that she does have TMJ syndrome. I'm also going to palpate the sternoclavicular. So we're going to go any tenderness.
No.
And then we're also going to palpate the cervical spine right here. So we're just going to any tenderness.
No.
And also the muscles back here, the trapezius and the rhomboids. Any tenderness.
No.
Perfect. Once we complete that, we're going to move on to range of motion for the cervical spine. So we're going to start off with flexion. So Gina, if you could go ahead and bring your chin to your chest. And then we're going to test for extension. So if you could go ahead and look up at the ceiling. Awesome, and relax. Next, we're going to move on to rotation of the cervical spine. So Gina, if you could look over one of your shoulders, and then go ahead and look over the other shoulder. Perfect. And then we're going to assess for lateral movement. So for this part, Gina, go ahead and bring your ear to your shoulder, and then the other side. Perfect. We're also going to assess for the range of motion for the TMJ. So for this one, I'm going to, Gina, have you open your mouth as wide as possible and close. So when we're assessing that, we're looking to see what the maximal opening of the mouth is. The patient should be able to place 3 of their own fingers vertically into their mouth. So to assess for the lateral movement, we're going to, Gina, I'm going to have you move your lower jaw from side to side. Perfect. Next, we're going to move on to the specialty test. So to test for the cervical nerve root compression, it's also known as the Sperling test. We're going to have, Gina, I'm going to have you turn a little bit. We're going to have the patient look over her shoulder and then up at the ceiling. Perfect. And as she's doing this, I'm going to position myself behind her. I'm going to stabilize myself here and just gently push down on her head. Any pain?
No.
Perfect. We're going to do that same thing on the other side. Any pain, Gina?
No.
Awesome. So when we're assessing if she were to have pain that radiates down the arm of the side that her head is turned, that would indicate cervical nerve root involvement. So after the Sperling test, we also want to take note that if a patient does have a serious spine injury or disease, or if they're a frail or elderly patient, we want to avoid this test because it can cause more trauma than good, essentially. After that, we're going to move to the feet and toes. So once again, I'm going to start by inspecting. So I'm going to come down here. Gina, if I can have a look at your feet and toes. So as I'm inspecting, I'm looking for swelling, calluses, deformity, corns, nodules, planters, any warts, bunions, things like that. We're going to look at the bottom as well. Awesome. Once we are done looking, we're going to test for flat feet. So for this part, we want our patient to actually stand up. So Gina, go ahead and stand up for me. So the foot arch does flatten so that the sole approaches or touches the floor. So the normal concavity on the medial side of the foot becomes more convex. So if you can see on this side, Gina has that nice little curve that we're looking for, which would indicate that she does not have flat feet. Go ahead and have a seat. Next, we're going to move on to palpating and assessing for interdigital neuroma. This is also known as Morton's neuroma. So I'm going to grab one of your legs, Gina. So it's going to be located between the third and the fourth metatarsal, and I'm checking for any pain or tenderness that may be radiating to the toes. So Gina, any pain? No. Awesome. We're going to do the other side. Again, between the third and fourth metatarsals. Any pain or tenderness? Perfect. And then after that, we're going to palpate for plantar fasciitis. This one, I'm going to palpate throughout the whole foot. I'm starting from the heel, moving up to the sole, and asking the patient if she feels any pain.
No.
And another thing we can do is also stretch out the fascia. So we're going to do that by gently pulling back the big toe. Any discomfort, pain? Awesome. We're going to do the other side. And so if she were to feel any pain while we're doing this, that would indicate plantar fasciitis. Once again, pulling back the toe. Any pain?
No.
Perfect. Now I'm going to palpate the interphalangeals and the metatarsal. So again, starting distal and going proximal. So I'm going to have you come back down. Any pain or tenderness?
No.
All right, the other side. Any pain or tenderness? Once we do that, we're going to check for range of motion on the toes. So Gina, if you could go ahead and curl your toes for me. Perfect. And then we're going to extend them out, so flare them up. Perfect. And then we're going to invert the foot. So if you could turn your sole towards midline. Perfect. And then we're going to evert. So If you can move your foot away. Perfect. That completes the foot. We're going to move on to the ankle. So for the ankle, I actually have you lay down. It'll just be a little easier for me. Perfect. So we're going to start off by assessing the ankles. And as I'm assessing, I'm looking for any swelling, deformity, nodules, discoloration, any joint symmetry issues, which I don't see. And then once we finish assessing, inspecting, we're going to palpate. So we're going to palpate the medial malleolus, which is the inside part, any pain or tenderness. We're going to do the lateral malleolus, which is the outside part, any pain or tenderness. And we're also going to do the Achilles, which is underneath. And so we're going to do that on the other one as well. Any pain or tenderness?
No.
Perfect. So once we do that, we're going to do range of motion. And for the ankles, we're going to do both active and passive. So we're going to start off with having Gina do it, and then I'm going to do it myself. So Gina, if you could go ahead and dorsiflex, which is put your foot up, perfect, and then point down. And then we're going to have her rotate. So you can rotate in both directions. Perfect. And now I'm going to do it passively. So I'm going to grab, and we're going to dorsiflex, plantar flex, and rotate. Same on the other side. Dorsiflex, plantar flex, and rotate. Perfect. When I'm doing it passively, I'm looking for any resistance or tightness, which I did not feel. So then we're going to move on to the knees. So if you can sit up, you can stay on here, it's really fine. Actually, we'll just have to come back onto the stool. For the knees, again, we're starting off by inspecting. So as I'm looking for any swelling, nodules, redness, alignment, symmetry. I'm also looking for any valgus or varus deformity, which I don't see. Then we're going to palpate. So we're going to start off by palpating the suprapatellar pouch, which is right above the patella. Any pain or tenderness. We're also going to do the sides of the patella, any pain or tenderness. And then we're going to do the popliteal fascia, which is underneath. This is where you would palpate for any Baker's cysts. And the same thing on the other side, any pain or tenderness. Perfect. Once we complete this, we're going to do the range of motion, and on the knees as well, we're going to do both passive and active. So first, I'm going to have the patient do it by themselves, and then I'll do it for them. So we're going to start off by extending the knee to 0 degrees, so straight out. Perfect. And then the other side. Awesome. And then we're going to have the patient flex the knee to at least 120 degrees. So go ahead and flex all the way back. Perfect. And flex back. Awesome. And then we're going to have kind of the knee out, and we're going to have the patient just bend the knee to the sides. So perfect, out and then in, and then the other side, out and in. Perfect. So now that she's done it actively, I'm going to do it passively. So Gina, I'm going to grab your leg, and so we're going to extend out to 0 degrees, flex back to 180, and then we're going to go out at the knee and in. Same thing on this side, straight to 100, flex back to 120, then we're going to abduct the knee and adduct the knee. Perfect. And also, again, when I'm doing it myself, I'm checking for any tightness or stiffness. We're going to move on to the specialty test. So for this, I'll have you lay back down again. All right, so we're going to start off by the valgus and the varus stress test. So we're testing for any meniscal damage that may occur. So for this part, we're going to have the patient raise their foot at about 20 degrees. For the valgus, I'm going to be placing my outer hand on the lateral side of the knees. I'm going to grasp the medial foot or ankle, and I'm going to abduct the lower leg, putting pressure on the knee. So I'm going to go ahead and do the valgus here, and then putting pressure on the knee while I'm abducting. Any pain or tenderness? Perfect. We'll do the same thing on this side. On the lateral,
No.
Perfect. And now we're going to do the varus, which is the same thing, but we're going to be putting our outer hand on the medial portion and adducting. So go ahead.
No.
The other side. Any pain?
No.
Perfect. And then we're going to go on to the Lachman's test. This is testing for any laxity issues in the ligaments. So Gina, I'm going to have you flex one of your legs at 20 degrees again. For this one, I'm going to be placing one of my hands on the lower femur, while the other hand holds above the tibial tuberosity, and then I'm going to pull and push the tibia. So this one, any pain or discomfort? No. Awesome. Do the other one. Any pain or discomfort? Next, we're going to move on to the drawer test. For this one, we want the patient to be supine as possible. I know this couch is not the best. And then, well, actually, yeah, we'll have this be done there. She's going to raise her leg up to 90 degrees. I'm actually going to have a seat on it. And then we're going to pull and pull. Also noting to see if there's too much movement on here. We're going to do the other one. And we're going to pull and pull. Perfect. Next, we're going to move to the McMurray's test. So this one, we're testing for the meniscus tear. We're going to immediately rotate the tibia and then extend the knee. We're looking for any laxity, pain, or crepitus. So Gina's going to have you straighten your legs and grab this. We're going to rotate. And we're going to just make a little M. Any tenderness?
No.
All right, we do the same thing with this. I'm going to rotate and then perfect. So that completes the knees. We're going to move on to the hips. So while she's laying down, I'm going to be inspecting. Obviously, with a patient, they'd be in a gown, so it'd be much easier to assess. But we're looking for any swelling, nodules, redness, alignment. And then we're going to move on to palpating. So I'm going to start off by palpating the anterior superior iliac spine. Just like right here. Any tenderness?
No.
Perfect. Then we're also going to palpate for the greater trochanter. This is the latter outer most part of the hip, which is right here. Any pain?
No.
Perfect. And now I'm going to have you stand up, Gina, so we can palpate the posterior superior iliac spine. I'll have you turn that way. And we're going to, any pain?
No.
And we're also going to palpate for the sacroiliac joint. This is kind of at the base of the spine. Some patients have that two dimples on the lower back. So any tenderness?
No.
Perfect. Once we do that, we're going to do the range of motion for the hips. So I'll have you lay back down, Gina. So we're going to start off by having the patient flex each knee at 45 degrees, and then we're going to have them externally rotate them out one at a time. So if you can rotate out and come back, and then rotate the other one, rotate out, come back. Perfect. And then we're going to ask her to keep it at that 45 degrees, but now she's going to rotate it internally. So you can straighten one of them, and then go ahead and rotate internally and back, and the opposite leg internally and back. Perfect. After that, we're going to test for the flexion of the hip. So for this one, Gina, I'll just have you raise your leg straight up one at a time. Perfect. And then I'm going to do these passive movements right now just because we're going to have her turn around, so it just makes sense for me to do it now versus having her flip-flop. So I'm going to do the 45 degree, and then we're going to rotate out, and then we're going to rotate in. Perfect. And then the same thing on this one. Flex, then we're going to rotate out, rotate in. And then we're going to raise the leg to test for extension, or flexion, sorry. And then that was flexion. And then we're going to have her turn around so we can test for extension of the hip. And while she's on her back, Gina, I'm going to have you raise your leg one at a time again. Perfect. Then now I'm going to perform the same thing. Also, like just looking for any resistance or tightness. Perfect. And then turn back around. And now we're going to assess for hip abduction and adduction. So Gina, one at a time, if you could just swing your leg out for me. Perfect. And then I'm going to have you swing your leg in, crossing over your other leg. Perfect. And then now I'm going to do it passively. So we're going to abduct and adduct. Perfect. Abduct and adduct. Now that we've done that, we're going to move on to the specialty test. So for this one, first we're going to do the Thomas test. This helps detect any occult hip flexion contractors. So Gina, I'm going to have you flex your right knee, and you're going to pull it all the way against your abdomen. So as she does this, we're actually assessing the other leg. This also does flatten the normal lumbar lordosis. So now we're looking at the other leg. If there is any tightness, her thigh would raise up, but as you can see, her thigh is completely flat, which indicates she doesn't have any tightness. So we're going to do the same thing on the other leg. Go ahead and raise all the way up. And again, we know that it's flat against the couch, which means she does not have any tightness. Next, we're going to do the Patrick's or the Faber test. So in this test, we're testing for the hip or sacroiliac joint disease. For this one, I'm going to have the patient place their foot on their opposite quad. So Gina, if you could take this foot, put it on your quad, perfect, and keep straight. And then I'm going to just apply some gentle pressure onto the knee. So if you can see, she made a little 4. I'm going to use this hand to stabilize myself, and then we're going to push down here. Any soreness or pain, tenderness? Perfect. And then we're going to switch over. So if you could go ahead and swap. Same thing, stabilize myself, push down. Any tenderness or pain? Perfect. And if she did feel the tenderness, it would be in the posterior hip or back, and that would be a positive sign for that. Next, we're going to move on to the spine. So Gina, I'll have you stand up and face the window for me. So we're inspecting first. I'm looking at the overall spine from the back, and I'm also looking from the side view as well. I'm looking for that, I'm looking for any cervical or lumbar lordosis or dorsal kyphosis, which I don't see here. We're also looking for that natural S-curve of the spine. You want to see the concave along the cervical spine area. It's going to round out around the thoracic. And then it'll again concave at the lumbar, and it'll end at the sacral area. The shoulders should be the same height, which they are, and as well as the iliac crest, which should be at the same height. We also want to note for any skin creases that's below the buttocks and ensure that they are symmetrical. For the purpose of this video, we're just verbalizing and not exposing our patient. So the next part, we're going to inspect the dorsal lumbar spine. So for this dorsal lumbar spine, and for this part, I'm going to have my patient bend forward as much as possible so I can assess the dorsal lumbar spine. For this one, I'm expecting to see a smooth curve and good alignment throughout the spine in this position, which I do see. There should not be any lateral deviation of the spine, and the shoulders should still be even. Nothing should be rotated. And this is also another opportunity for us to assess for any signs of scoliosis. When the patient is bending, I'm also noting the level degree of the range of motion. So normal ROM in this position is approximately 90 degrees. I'm also going to place my hands on their hips and assess for evenness. If the patient were to have uneven hips going up, that would indicate that there is some discrepancy in the length of their limbs. Next, we're going to go ahead and palpate. So I'm going to start around the C7 and work my way down. I'm palpating for any tenderness. So just palpating the spinous process as I go down. Any tenderness, Gina? Perfect. I'm also feeling for the intervertebral spaces. Any tenderness? No. Perfect. If there is any suspicion for spinal fracture, we can place our hand flat, and then using the ulnar surface of our hand, we can percuss down to see if there's any pain. Any pain, Gina? All right. Perfect. So we're going to check for range of motion now. For this part, I'm going to actually be behind the patient and have her back face towards me. I'm going to take this stool's kind of high. I'm trying to take a seat. Get a little closer. Take a seat. And I'm going to stabilize her pelvis. And now I'm going to have you bend from side to side at the waist at about 30 degrees. Perfect. And then I'm gonna have you extend your back backwards 30 degrees. Perfect. And then we're going to have her rotate, twist her shoulders about 30 degrees. Perfect. Once we've completed that, we're gonna move on to our specialty test. So Gina, I'll have you lay back one more time. So this is called the straight leg raise, and it tests for sciatica. So I'm going to raise the leg and assess for any pain. Any pain, Gina? Any pain?
No.
Perfect. And so if she were to have pain, that would indicate that she does have sciatica issues. That ends my musculoskeletal exam. Any questions, Gina? Perfect.